Good day, everyone. My name is Sarah Henniger, and I am a member of the coordinating committee and also a member of the subcommittee for the webinar planning. I wanted to welcome you all here today to hear more about the issues surrounding mental health and addictions for Nova Scotians. I will be introducing all four speakers, and each speaker will have approximately 15 minutes. And I'll give them a little secret message of when that will happen. I will hold all questions until the end. And there is a chat function. I think most people are probably familiar with that. And so you can put comments or questions in the chat function. And then following all the presentations, we will proceed and try to address some of those. I would also like to acknowledge before we begin that we are in the Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship, which Mi'kmaq and Maliseet people first signed with the British Crown in 1725. I also want to say a big thank you in the beginning, in case we run out of time at the end, to all the speakers who took the time and agreed to come and do this presentation with us. So thank you all. First, we will have Nabiha Atala, who has over 25 years experience in leadership roles at Immigrant Services Association of Nova Scotia, ISANS, as most of us know it, a large multi-service immigrant settlement agency in Atlantic Canada. Currently, as advisor on strategic initiatives, she leads ISANS research strategy and advises on policy development, sector best practices, institutional knowledge integration, and government relations strategy. She previously held the roles of the Manager of Business Development Services and Manager of Communications and Research. Nabiha was born in Egypt and immigrated to Canada with her family when she was 7. And prior to moving to Nova Scotia, she taught and developed English as an additional language program for 10 years in Vancouver and Winnipeg, as well as in Cairo. Our second speaker is Bev Kadam, and Bev's place of origin was the province of Saskatoon, and she says that she danced her way across Canada, experiencing the diversity of her country through an ambitious desire to pursue this childhood dream. In 1993, Bev was hired she returned to Nova Scotia in 1986, and she decided to return to the world of academia. She moved across country to do this. She enrolled in the Bachelor of Recreation program with a focus on therapeutic recreation at Dalhousie, and graduated from that program in 92 and was grateful to enter the workforce immediately with 2 part-time positions. One with Beaverbank Nursing Home as a rec coordinator, and the other at CMHA Dartmouth branch as the social support worker. Bev's work with CMHA inspired her to pursue her master's in dance movement therapy, which right now is on hold, but she definitely hopes to be able to use that. Over the years, she's had the privilege of using her dance movement training with members of the different programs, as well as youth and learning resource centers at Millward High. In 1999, Bev also had the good fortune of being one of the co-founders of the Eating Disorders Action Group, now known as Eating Disorders Nova Scotia. And additionally, she is founder of the annual Dancing in the Sky Vigil Committee for Suicide Awareness in Eastern Shore, Nova Scotia. Bev is an active community member committed to reducing barriers for those living in poverty and experiencing mental illness. Currently, she sits on many community advisory committees, including the Society to End Poverty Advisory Committee for PDPP, Personal Directed Program, Dartmouth Community Network, Mental Health Community Network, and of course she continues her work with CMHA, and I believe has been there for close to 30 years. Next, we will have Dr. N. Sariski, originally from Montreal and recently moved to Nova Scotia after many years working and living in the United States. Anne has a background in community mental health, palliative and hospice care, community organizing, and public health. Most recently, she served as vice president of a large hospital system in Louisville, Kentucky, as well as teaching adjunct social work classes and supervising practicum students. As the professional practice and advocacy consultant, and is responsible for membership and community stakeholder engagement. This includes developing, implementing, and facilitating professional development and community development activities in solidarity with members and community partners that advocate for social justice. And our final speaker today will be Nancy Ross, who is an assistant professor in the School of Social Work at Dalhousie University. Her previous work as a clinical therapist in mental health and addiction services motivates her research interest in calling attention to the prevalence and impacts of adverse childhood experiences and gendered violence, and in defining better measures for intervention and prevention. She applies a feminist, peacebuilding, and trauma-informed lens that acknowledges structural and cultural forms of violence that are inseparable from direct forms of violence. This analysis moves from a narrow focus on individual responsibility to encompass a wider analysis of the social, cultural, economic, and political origins of violence to ultimately compel community responses. How might justice systems, healthcare responses, mental health and addiction services, and educational institutions better respond to trauma to support individuals and families are questions central to her research. So thank you to all speakers, and we will begin with Nahiba.
Hello, I'm just going to share my screen. Is that appearing for people? No, yes,
No.
no?
No.
No. Okay. I'm clicking on the share button and it's not doing anything.
Alec, can you help us?
It's disabled, the share screen option.
How about now?
Oh, there you go. You're good to go.
Okay. Okay, great. I'm very happy to be here with you. As you may have noted from my introduction, I'm not a specialist in mental health, but I have a lot of experience in working with the immigrant community, and I hope that I'll be able to give you that perspective this morning. So just to bring you up to date on ISANS, I'm sure you've heard of us. You may not know how much we've grown in the last several years. We're quite a large organization now, over 300 staff from over 60 countries. And in 2019, our last regular year, we served over 10,000 clients. So what I'd like to speak about today is a bit about immigration, who's who, the mental health of immigrants when they arrive, common mental health problems that we have noted among our clients, issues around access to services, the added layer of COVID, systemic issues, and then hopefully ending on a more positive note of what we have found helps. So we use the term immigrants quite loosely nowadays, but really there are two groups that need to be distinguished from one another. Traditionally, immigrants referred only to permanent residents, that is, people who have come to Canada intending to stay. And these people would have almost all the rights of citizens, and they would be eligible for all settlement services offered by organizations like ISANS. They come under three categories: economic, family, and refugee. And in 2019, Nova Scotia accepted 7,580 such immigrants. Now, a faster growing group are the temporary residents. This group has been rapidly growing across the country, and these are people who come on a time-limited visa. They are not legally allowed to stay in Canada unless they renew their visa or transition to permanent status. So they may apply to transition, but they're eligible for very few settlement services while they are temporary. And this includes temporary workers, international students and graduates, and refugee claimants. In 2019, we received twice as many temporary residents as permanent. Internationally, often temporary residents are referred to as migrants. So you will see in this presentation that I include both immigrants and migrants, both permanent residents and temporary residents, although most of our experience at iSANS is with permanent residents. We're not funded to support temporary residents except in very limited circumstances. However, the challenges for temporary residents are often similar to those for permanent residents, and in fact, there are additional challenges which may impact on their mental health. So when immigrants first arrive, most are quite healthy and quite resilient. Especially we're talking about the majority of immigrants who choose to come. Those who are in the economic category, which includes 60% of permanent residents, are those who have made the choice and probably done a fair bit of research, are realistic about what they are going to face in Canada. However, if settlement stress builds up, it can impact negatively on everyone's health when it's not addressed. And so, regardless of what category immigrants have come under, we need to acknowledge that the settlement process has stresses that can be a challenge. Welcoming communities and settlement services supports are very important to supporting immigrants' continued well-being. In 2014 to 2016, iSANS conducted an extensive community consultation with immigrants about mental health and wellness. And a lot of what I'm going to tell you today comes from that study, which you can find on our website. I will give you the link at the end. We discovered that immigrants are interested in talking and learning about mental health and wellness. They understand the issue of stigma and they want to challenge it. And generally, they have a holistic view of mental health, and they understand as well the social determinants of mental health. So that understanding and awareness is a very good starting point for addressing mental health issues.
Nabia, I'm not sure if you can hear me. It's
Yes.
Danny Graham here.
Yes, Danny.
I'm assuming that you're intending to advance your slides on our screen.
Oh, are they not advancing?
They're not advancing. Yeah. Not sure if that's just a quick click or what it might be.
They are advancing for me, so I'm not sure what I should do. Is there someone who can provide tech support here?
Let's try unsharing your screen for a moment. They did advance now, so I don't know if you did anything on your end, but we did see them.
I escaped from the slideshow mode.
I think that's the issue, is the slideshow mode, as opposed to going from the beginning. Like when you're in that slideshow, just see from the beginning.
That's what I did.
So
At
if
the
you
beginning, I clicked on from the beginning.
If you just present from the format that you're in now, can you try moving forward for us?
Yeah. Just a sec.
Yeah.
How's that? Did
Good. So maybe
okay.
if you just stay in this mode, then we'll see the advancing. And thanks for folks for flagging
Okay.
that. Yeah.
Yeah, thank you, Danny, for pointing that out. I think you can probably imagine some of the common mental health problems, issues relating to adjusting to a new culture, isolation, especially crucial for those who've come from societies where the extended family is really key. And now they are away from that extended family. And we all know that it's hard to start in a new place to build friendships. It takes time, regardless. Communication issues, not only language skills here, but the culture involved in communication is a big issue. Feelings of not being accepted, anxiety about family members left behind, and previous trauma, especially relevant for refugees who come. In addition, one thing that immigrants often don't anticipate is the change in their social or economic status. Not being able to work immediately in the job they were trained for, trying to provide support as well for family overseas at the same time. In some cases, not being aware of services and or facing difficulty accessing services. And for the primary candidate who may have come with the skills and experience and are the person who was accepted for immigration, they may start to work fairly soon and find that family members experience all these issues more acutely because they have not integrated so quickly. As well, we know that racial and systemic discrimination have a big impact, including those built into government policies. We know there's domestic violence and abuse in immigrant communities to some extent, and addictions, though I will not get into these issues in detail today. We at ISANS recognize, I try to identify and refer people for these specific issues, domestic violence and addictions, to community service providers. And we do have crisis workers who are trained social workers who are the first line of response for our clients. So around access to services, the first issue is lack of information, but a really, really huge issue is the lack of interpretation services. This has a big impact when people are trying to access mental health services, because even if someone speaks English quite well, they may not be able to express their challenges comfortably through in English and even through an interpreter. There's that layer of interpretation, but also intercultural competency, any trauma, mistrust of the system, and then uncoordinated systems complicate everything. When we add COVID, we all know that's been an added layer for all of us. For immigrants, there's anxiety about family overseas where the COVID circumstances may be worse, concern about their own and immediate family issues here, additional layer of isolation, difficulty understanding through masks, difficulty accessing services online, and these are especially issues for the most vulnerable clients, those who have beginner English skills or literacy challenges, and those who've suffered trauma. Systemic issues are also very, very present for immigrants accessing mental health. Often immigrants' requests for services don't present as serious mental health illnesses. Training interpreters on mental health issues is a complex issue. And then also training clinicians on how to work with interpreters. Developing teams that can really support a counseling situation that would give people a feeling of safety. The issue of intercultural competence is still a challenge in delivering mental health services. What helps? So we know that including immigrant community members in planning sessions is really a good practice. Not just doing things for them, but with them. Community programs that we have run for many years at ISANS have proven to have a positive impact on healing and recovery. Peer support is also very valuable for reducing isolation, and an adult education approach that acknowledges previous experiences, abilities, and has an empowerment attitude. We found that talking about stress opens the door to discussing mental health and wellness with a good level of comfort. And that when people understand that mental health recovery is possible, then they are more willing to challenge the stigma. Immigrants benefit, as all of us do, when there's collaboration among service providers. And in the case of immigrants, we would add settlement staff to the mental health service providers. Immigrant needs are also better addressed when they are involved in a long-term process of institutional change rather than just called in for one-time consultation. So responding to immigrant mental health needs requires flexible structures that for the most part are not currently in place, but we need to work towards. That is my presentation for now. This is the link, and I can send it to the organizers for the documents from our extensive research into this issue. Thank you for your attention.
Great, thank you very much. Very well done. Certainly clearly outlines the issues. So we will move now to Bev Cadam from CMHA.
Oh, you're on mute
You
there.
are muted.
There. Bev Cadam, and I'm one of the branch co-managers for the Canadian Mental Health Association Halifax Dartmouth branch. The other branch co-manager is Marg Murray. Together, we have been here an excessively long time. I've been here I guess that's half a century. Definitely mental health is an issue of grave concern, particularly during COVID. A lot of this mental health and addictions were exacerbated. If people don't know about our organization, we're a not-for-profit organization that provides social support services for adults living in the community experiencing mental health issues and mental illness that are marginalized, living in poverty, and experience a lot of challenges with regards to all the social determinants of health. So we run social support programs, two of them. One of them is in Dartmouth, one's in Halifax, and Marg runs a Building Bridges program, which offers one-on-one volunteer support to adults living with severe to persistent mental illness. And unfortunately, during COVID, that was one thing that kind of had to get put on the back burner because of the restrictions and protocols put in place by public health with respect to meeting in close proximity with people who were outside your bubble. So, and our social programs during COVID actually had to shut down, and we transformed into an outreach service within a week based on the collaborative approach of our members and staff and volunteers and the guidance of the branch co-managers. So the individuals we serve are age 19 to 70 years of age. However, the majority are in their 50 to 60 years of age. We've all aged together over the years. So we have established quite a family that's built on trust and a level of support because we have been here so many years. The members feel quite close to us. Many do not have families of their own biologically who are involved in their lives. So we have become that family unit for many of them, and we will advocate and refer and support them to the best of our abilities when they're following along the continuum of their mental health and wellness. So we established our organization in 1956. It was originally started by the White Cross. And many of the programs that have branched out from our organization, one of them being the Lake City Woodworkers. It actually started in the basement of the Dartmouth Mental Health, Canadian Mental Health Association. Unlike some of the Canadian Mental Health Association branches across Canada, we are a very grassroots branch. We do not provide case management, and we don't have, in Alberta, they have a recovery college that is open. We are very grassroots, hands-on with the people in the community, and do not provide counseling services within our organization, nor do we run housing or employment services, because those are offered by other organizations in our community who we partner with on a regular basis. And a part of our membership is also affiliated with some of those other organizations for housing and employment. So we work very collaboratively with those and in partnership. So COVID, well, we've all been impacted by COVID. COVID actually there were many good things that came out of COVID. I'm like a little bit of a Pollyanna. I always see the optimism in everything. As much as COVID was very challenging on our community and for the people living with mental illness and mental health problems, I think it brought to light some of the issues that we as organizations working in community have been trying to address for decades, and they could no longer be negated or overlooked. How all of the social determinants of health came to the forefront, and government really had to take a stand on looking at those issues with much more, I guess, yeah, with a greater sense of purpose. Housing has always been an issue, and it's now on the forefront because now we're in a housing crisis. And with COVID, because of public health limitations on how many people could be in one space at any given time, it reduced the numbers of people who were able to access the shelters. And so we saw an increase of homelessness, which we still are struggling with, although they are scrambling to come up with ideas. But as we all know, some of those ideas were not well received with the riot that happened, unfortunately, on the old public library grounds, which people's houses were torn down and they now no longer had a place to rest their heads. Now government is kind of stepping up to the plate and looking at where they can put temporary housing to make sure that there's warm shelters for people over the winter months, so we don't see people unfortunately dying from hypothermia on the streets of our city. So we sit on a lot of committees, so we're very involved in also trying to advocate on behalf of housing and very many of the different social determinants of health. Housing also for us is something that we've struggled with many of our individuals because of eviction notices and rent eviction notices, which increased over COVID as well, and trying to place people in affordable, accessible, safe housing within HRM is next to impossible at this present moment in time. One of our members, we just finished working in collaboration with a housing authority, a nonprofit housing authority, after 6 months found her a place. But the average rent right now is starting at least $1,000, if not more, which is not within the affordability of someone who's on income assistance or disability supports program. The other thing that we found also is the social isolation and disconnectedness with our community. As a result of COVID, a lot of things went online. And this was presuming that everybody had access to internet or data. the majority of people do not have that because they cannot afford it. So transitioning to a virtual world was next to impossible for a large percentage of the people who access our programs. Even if they had cell phones, they could not afford data. Internet was just way beyond their capacity to afford. So, and I mean, they could do telephone. Some people really like the telephone calls to their counselors and doctors. Other people found it very anxiety provoking because they missed that one-on-one connection with the people who support them in their world, right? So that was a big challenge for some to adapt to. And we are also fighting to conquer this digital divide, which I know we are not the only organization who experienced it with the individuals who access their service. There are many other organizations who work with individuals living in poverty who were running up against the same issues of concern. So one thing we have to realize is that everything is going virtual. Then to have access to internet is not a privilege, it's a right. And we have to fight for that tooth and nail, because it's very exclusionary. It increases the whole concept of social isolation and lack of connectedness. And if you're living with a mental illness, to not have that social connection has a significant impact on your health and well-being on a day-to-day basis. When we were in lockdown and we had to shut down our programs, it was very challenging for individuals because they used our service as their social support connection service. And they were coming into our programs, sometimes once a week, twice a week, 3 times, some that came every day. This was their family, these were their friends, this was their peer group. And all of a sudden now they're left in their apartments with no connection through internet, no data connection, and some may be able to afford television, some may not, but it's just that complete social isolation piece that was overwhelming for so many of the people who we serve. And their mental health was severely impacted. What we did, we had probably made 400 telephone calls per month. We were accessing them by phone 3 times a week. Some of those phone calls lasted 5 minutes, some were an hour, depending on where the person was and what their needs were at that time, in that moment. We also through grants. What's that?
You have about 3 minutes, Bev.
Okay, through grants we received. Okay, we received some grants through COVID, which really helped to allow us to share and do all the necessities, share all the things with our members that we could. So we actually purchased food. We put together social isolation packages that were filled with activities. We did drop-offs to members at least 2 or 3 times a week with all of those. Distance visiting, everything was following protocol. One of the things that which members really enjoyed, one of the things that we found challenging around the vaccination into public health, which I think is important to note, is that we are not an essential service. So a lot of the protocols and restrictions that were put in place, we were a little confused as to where we fit into all those policies. So I think we always needed more clarification on where do agencies who are non-essential, providing non-essential services, fit in to the public health protocols and restrictions. And we were always combating with this. One of the things that came out of it, we were through another grant that we received, we developed an emergency an emergency preparedness plan for our branch, which we had never had. So we were able to complete that through a grant that we received. And also what we did through that grant is we put emergency preparedness packages together for related to COVID. So, and those were all hand delivered. So they and things were explained, and I'm seeing telephone numbers and for people during COVID and some of the crisis lines that they could call if they needed extra additional support. So there were a lot of positive things that we need to continue to address the issues that we around the social determinants of health looked over decades. Because if we're going to provide a healthy environment for everybody, I think we really need to address all the social determinants of health and make sure we're following and implementing and meeting the needs of the individuals, specifically those who live with mental health issues and addictions. Excuse me. Now, if there's any questions afterwards, please don't hesitate to ask.
Great. Thank you, Bev. And now we will move to Dr. Zariski.
Okay, thank you very much. So I am going to share my screen, and here it is. Hold on one sec. Okay, I'm going to share it. Does everyone see my screen?
Yeah.
Yes, okay. So I am acknowledging that I'm speaking from Mi'kma'ki, which is the ancestral and unceded territory of the Mi'kmaq people. And I give thanks to all those whose land we are on, and acknowledge that we are here by right of the peace and friendship treaties that were signed from 1725 to 1779, and that were reaffirmed in 1982. And that I, along with the Nova Scotia College of Social Workers, where I work, and all of our community partners, join in the labor of reconciliation. And we are grateful to live and work together as treaty people in Mi'kma'ki. And I was asked specifically to talk about the impact of COVID-19 on the queer community and the trans community in particular. So that is what I will be talking about. I just changed my screen to a different slide. Does everyone see it?
Yes.
Okay, great. So as Bev was speaking, obviously COVID-19 has increased issues around mental health for all of us. And, 46% of people in Canada report experiencing anxiety or worry due to COVID-19. And 38% feel like their mental health has declined as a result. So certainly this is true for everyone, but for vulnerable populations, this is worse, in part because of intersectionality. So intersectionality is where we recognize that depending upon where we are situated in terms of this wheel of power and privilege that you see on the right, if we are more marginalized or we have more power, we tend to experience a combination of different perspectives. And we all have our own unique experiences of discrimination and privilege, because intersectionality is a lens through which you can see where power comes and collides, where it locks and intersects. So for people who might identify as gay or transgender, we tend to primarily have additional sources of stress that are unique to our experience that will tend to make our mental health challenges more difficult and therefore our COVID-19 experience more challenging, as I will explain. So there are certain unique forms of hatred for queer individuals, whether it's rejection from parents and family for being oneself, rejection from God and organized religion, rejection from healthcare providers and lack of recognition of medical needs, and sometimes often being told that one does not even exist. So these are just a few of the many unique forms of hatred that, in addition to other types of racism, can cause a lot of different problems, discrimination in social settings, internalized stigma, as well as relationship violence, and then broader social forces where we still may not experience ourselves as having all of the rights that our cisgendered white Christian counterparts might have. So in terms of rejection levels, that you'll see will intensify the kind of stress that we experience, and that will in turn lead to an intensification of the kind of trauma that we experience. The not feeling safe by one's own family or by God is a unique form of trauma to the queer community that is especially challenging and makes transgender and gay people especially vulnerable. So LGBTQ individuals are almost 3 times more likely than others to experience mental health conditions such as major depression or generalized anxiety disorder. We must experience stigma and prejudice on a daily basis. As a result, we may be more prone to using different substances in order to deal with this kind of stress, which then leads to additional challenges. And LGBTQ youth are 4 times more likely in questioning, are 3 times more likely to attempt suicide. And in part, it has to do with what it means to be a youth. It means that we are often stuck in homes where we are told that we don't exist, where we are sometimes punished as a result, or we are rejected. So we don't experience that kind of unconditional love that many children are ideally supposed to receive, which can cause a lot of deep-seated trauma, as well as additional components like homelessness as a result. So when coronavirus hit and we were told to stay home and save lives, that doesn't always save lives. And that's not true uniquely to transgender people. We saw issues around domestic violence dramatically increase as a result of COVID, because home is not safe for everyone. And sometimes staying at home does not save lives. And especially when it comes to LGBTQ two-spirit youth from who are living in homes where they are not safe, they either are more likely to attempt suicide or they are more likely to become homeless as a result of the ways in which they are trying to experience a sense of safety. And sometimes living on the street is more safe than living in a home where one is being abused. So addressing the intersectionality of LGBTQ health and how that intersects with poverty, injustice, homelessness is one of the many challenges that was aggravated as a result of COVID. So we know, for example, that 40% of homeless youth in Canada identify as queer, and especially many will experience shelters as not feeling safe. They may feel discriminated. There may be increased violence within the shelters. And then there's a challenge with transphobia, where shelters are often segregated by male floors and female floors. And youth will be segregated based on how shelter staff perceive their gender instead of how youth actually identify, which can lead to additional stressors and potential violence. And so indeed, suicide is a very big risk that is often magnified by the fact that shelter policies are generally not as inclusive as they ought to be. And so we know that research shows that trans individuals in particular have significant risk of suicide. And we also know that the risk of suicide decreases by 93% with strong family support. So, so much of what needs to be done has to do with the ways in which trauma is impacted by violence and by stigma, and a lot of family education and working on education of the broader society is key. Now, we know that already prior to COVID, according to the Human Rights Campaign Foundation Youth Survey data in 2018, so that's pre-COVID, 95% of queer youth report trouble sleeping at night. 67% of queer youth hear families making negative comments about their identity, about LGBTQ plus people. And only 24% of LGBTQ plus youth express that they can definitely be themselves as an LGBTQ plus person at home. And so the experience of not feeling safe at home causes profound psychological damage that is not easily reparable. And so when everyone with resources, shelters in place, those without resources or safe shelters are at a special risk, and existential concerns tend to be heightened in general. Additionally, whatever public resources, as Bev shared, that are not deemed essential were shut down, and many are still shut down. So this is from Pride Health, talking about all of the different services that were in place in order to help the two-spirit, lesbian, gay, bisexual, transgender, queer, intersex, and agender plus communities. And we see that many of them were closed due to COVID. Many are still closed. And so this means that many people were not able to access their hormones, were not able to access gender affirming surgeries, which is an additional source of concern, because we know, and this is again from Pride Health, that every delay will cause more mental health anguish. And indeed, the majority of people who do try to harm themselves tend to do so while waiting for services. So every delay causes an increased risk for people whose gender identity is not yet actualized. So when asking about the issue of COVID-19 and transgender mental health, intersectional prejudice and injustice means more risk, greater trauma, and worse outcomes. And these are magnified and compounded during pandemic situations, putting more marginalized populations, not just transgender or queer individuals, at greater risk. Now, what is unique about the queer and transgender community is that fundamental sources of resilience available to other marginalized groups, like family and faith, are not only often absent, but often those areas are sources of trauma, which can make these individuals more vulnerable, and everyday experiences that other people can draw strength from, family, homes, even going to the bathroom for a safe moment, are not safe. And greater wait times for what services are available and possible means increased risk for harm and self-harm in the meanwhile. Furthermore, the life and death urgency of COVID can lead some to prioritize COVID-related policy changes over others. So I kind of agree with Bev that there, as a result of COVID, there are increased risks as well as increased opportunities. Now, on the one hand, as I mentioned, there delays in service increase risks. Forced sheltering with unsafe family increases risk. Financial insecurity for already marginalized individuals increases risk. Health risks increase for individuals who are already marginalized, and coping is decreased for people whose resilience is already impacted by intersectional oppression. And the consequences of unequal access to medical care are especially evident in COVID outcomes themselves. On the other hand, we know that mental health challenges have renewed attention, indeed even renewed funding, as Beth pointed out. There is an increased understanding of intersectionality, and COVID has forced silos to come together for the common good. There is renewed recognition of the ways in which we are interconnected. What impacts one of us will impact all of us. We can't just say, oh, we're not going to take care of COVID for people who are homeless, because ultimately we are all interconnected. We're all sharing the same air and we all deserve the same rights. So the gaps and cracks in our healthcare system and in our policy system have been exposed. And there's also growing consensus of the importance of including mental health and services for the social determinants of health to include and ensure health. And there's also growing understanding about what is the psychosocial determinants of health. And systemic structural prejudice is a huge part of that. So I'm going to share one policy. It's the gender affirming care policy that we are one of the many different supporters of, and perhaps each of you listening here will go and learn a little bit more about this policy that is trying to advance and use this as an opportunity, this moment in time as an opportunity to advance healthcare and actually work to make Nova Scotia a world leader in being gender affirming and inclusive. So one of the components of the policy, I'll do a very quick overview, is that there are too many barriers that stand in the way of those who are seeking gender affirming care in Nova Scotia currently.
You have about a minute, sorry. You have about a minute.
No worries, no worries. So this means reducing the number of assessment letters and all of the hoops that individuals need to jump, as well as expanding coverage. While gender affirming care is covered, only a very small percentage of it is currently covered. And so there's an advocacy for expanding it, recognizing it as medically as necessary, turning the individual as the primary assessor instead of all of the gatekeepers, looking at expanding Pride Health and Pride Health funding, recognizing that gender affirming care is good for seniors as well as individuals with disabilities and for minors, as well as working to limit the non-consensual treatment that happens for individuals who might be born as intersex, and working to depathologize transgender health. So if you're interested, you can go to GAC in Nova Scotia. It's a great website. We are one of the many different, as is the Canadian Mental Health Association, of official supporters, and more supporters are ways that we can work to make Nova Scotia more inclusive for all during this time. And that's the end.
Thank you so very much. Very informative, lots of information. Thank you. And our final speaker then is Nancy Ross.
Okay, I'm hopefully going to be able to share my screen as well. Let's see. How's that working?
I don't see anything.
No, we don't see it. Oh, it's starting. Yes, you're good.
Good?
Yes.
All right. Okay. So this was thank you so much for inviting me to be part of this panel. I think
Nancy,
everyone is raising such profound ideas. Yes?
I'm going to stop your video because it's very hard to hear you. So if we stop your video, it might be, we might not be able to because you're screen sharing. Sorry.
Maybe I could check on that. Is that good?
Yes.
Yeah, that works.
Okay, that might be better. All right. So I too want to acknowledge, as a member of Dalhousie faculty, that we are located in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq, and we are all treaty people. So today's topic is huge, and I actually found it extremely difficult to think about what I could fit in 15 minutes. So I will do my best. So basically, we were asked, I believe, to talk a little bit about the impact of COVID, then for me to look a little bit at the mental health and addiction services delivery program across the province, and then point to where we could go in the future. So that's the tall order. So I just wanted to start by recognizing a little bit around the impact of COVID-19. And just to, I guess, reinforce what all the other speakers are saying, that in many ways it's called attention to social inequity, racism, childhood adversity, gender-based violence, that and they underpin all our collective well-being and mental health. And I like Gabor Mate's work, and what he suggests is that a hurt is at the center of all addictive behaviors. And I wanted to reference the pervasive adverse childhood experiences that exist in our society and impact most individuals living in our communities and also across the globe. So this is a big slide. So I just want to reference it in case you're not familiar with this concept and the studies. There's over 3,000 studies now that look at adverse childhood experiences and how they occur. They occur in the social realm. They occur in our relationships, in our families, and in our communities. And here you can see on this slide that these adverse childhood experiences are related to divorce, homelessness, parental mental illness, substance abuse, emotional and sexual abuse, domestic violence, bullying, physical and emotional neglect, etc. So there's a huge intergenerational component to these adverse childhood experiences. And then if we look at number 2, we're looking at the community, which is meant to support us all. And I don't know if you can see this slide well, but what it is pointing out is the social determinants of health. And it recognizes the impact of historical trauma, colonialism, racism, poor housing, and some of the factors that we've been already discussing. And then the third one looks at our environment, and it recognizes that the impending climate crisis affects all of us as well. And then I just wanted to also point out a small study that we did in Lunenburg, Nova Scotia around adverse childhood experiences. And we were able to survey 226 people, and it just confirmed that adverse childhood experiences are pervasive in the province. And the highest, the ones experienced most often were living with someone who abused substances, and a member of a household who had a parent experiencing a parent who had mental health issues. So again, those intergenerational elements are so important in terms of our approach to responding to mental health and substance abuse issues. So this is a study that I found that I also wanted to point out to you as well, that you might want to reference later. It's noting that depression has deepened in older Canadians, and it was conducted by a Dal-led research team, and that it points out that older adults had twice the odds of depressive symptoms during the pandemic compared to the pre-pandemic. And of course, for those already marginalized or socially isolated, this was exasperating. And then I just had a few slides like pointing out the impacts of COVID-19. And I think we're well aware that violence against women and children has often been referred to as a shadow pandemic or a second pandemic. And then also racism has been referred to as a pandemic. And then also loneliness, it has been referred to as a pandemic. And in the UK, people may know that there's a ministry of loneliness. So just a recognition that in many countries now, loneliness is a chronic problem experienced by many people. And then I wanted to bring your attention to a report that was a result of research that I was involved in with Dr. Katrina Brown and Marjorie Johnston that looked at the role of social work in mental health and addictions across the province. And I would say the results of this survey and this research really invites a call to action. And the survey participants that basically here you can see a little bit of the results, that 98% believe that there needs to be changes made to the current provision of mental health and addiction services. So many people in the province are referring to the state of mental health and addiction services as in a crisis. And that is, you know, I can give a personal example of a niece of mine who was in a crisis and needed to access services. She's 16 and she was told at the IWK this week that she had to wait 4 months for another appointment. So we can see that that's just a personal example that is, we can see that so many people are finding inadequate responses by addiction mental health services. And the social workers who work within these systems are unhappy. They feel, for the most part, only 35% indicated they were satisfied with their current role, and most believe that there are not sufficient resources available and not enough attention paid to the factors that we're addressing in this seminar around social determinants of mental health. So one of the critiques is about the biomedical model, currently influential in mental health and addiction services. Basically, within that model, it positions the therapist as an expert. It looks at the individual in terms of what is wrong with that individual, a very individualized approach. And it is looking at mental illness often as a biological disease of the brain. It's inevitable, incurable, and genetically determined. So it's very symptom driven. And what we found in our research is that neoliberalism has forced cost containment and efficiency to be the driving force of policy and program choices. So this is highlighted by this quote by Elaine, who was a supervisor. This is a pseudonym. Elaine is saying, social justice, yeah, right. That's not driving this. Real people. Efficiency is driving this. It's the factory model. So I found this quote to be very powerful in terms of looking at the current offering of mental health and addiction services as a factory. So the dominant use of the Diagnostic Statistical Manual of Mental Health Disorder and the medical model continues to perpetuate the myth that mental health issues are internally based within the biology mind of the individual. As social workers, we understand that the family system and other social determinants of health impact people's overall well-being, including their mental health. So we made a lot of recommendations in this report. As you can see here, this one is looking at social policy and prioritizing mental wellness of Nova Scotians. And one of the first ones that I think is really important is the call to increase mental health and addiction services to represent 10% of the total Department of Health and Wellness budget, as recommended by the World Health Organization. And then again, resonant with all of what our former presenters were saying, we need to look at a guaranteed income for Nova Scotians. That when we're saying that people who live on social assistance cannot afford $1,000 rent, we're setting them up for mental health problems. So when we look at, and then to re-examine the tiered framework and the way that CAPA service delivery models that are putting a stronger focus on the bio psychosocial model. And then we need to look at create a plan for all regulated mental health professionals to build to MSI. And that is because we need to explore how we can make services more accessible. And then this second principle is address social inequities in mental health and addiction services to ensure that we hire more diverse social work people, social workers and other mental health providers, develop and offer community and culturally appropriate services to African Nova Scotians, Indigenous communities, to SLGBTQIA+ people and other identified people, and offer gender-specific services that address coexisting issues of mental health, substance abuse, and trauma. And then this third principle is looking at the lifelong individual mental wellness and healthy communities. So Nova Scotians should be offered more community-based practice. We need to challenge the dominance of the biomedical model and expand services to provide greater choice. And look at developing alternative non-biomedical services and resources such as art, music, dance, animal-assisted interventions for children, youth, adults, and diverse communities. And there should be a range of mental health services and interventions that people could choose from. We need to remove current policy that predetermines the number of sessions the client can receive. And where there are coexisting concurrent relational injury, trauma, mental health, and or substance abuse issues, sessions of counseling should be provided across a wide range of mental health issues. And then the principle number 4 is looking at critical mental health programming and community collaboration. So provide greater opportunity for social work input. Look at the ways that we can expand the role of and redefine what a clinical therapist is, and looking at ensuring that service delivery is collaborative and contextual. And then I was in preparing for this workshop, I was looking at some literature. And basically what I found is that let's break open the narrow box into which mental health and addiction has been put by policymakers and the healthcare system. So an individual disordered biomedical disease-centric paradigm has frozen action and limited understanding of the breadth of social life that fuels and relies on mental health. This needs to end. So transformation demands centering the social determinants of racial and economic oppression and inequity. So I think we're called at this moment to reimagine mental health systems post-COVID and during COVID. So now is the opportunity to make securing the emotional and mental well-being of humanity a common expectation of global governance. And an article I found in the Lancet looked at it references the International City and Urban Regional Collaborative, a consortium of mental health system leaders. They are saying, let's be ambitious. And I'm saying, let's be ambitious. Social emotional health is key to the state of communal life and well-being. COVID-19 has underscored and magnified these connections. So unless there is a bold change, remutable social factors, poverty, food insecurity, unstable housing, childhoods of diminished education and nurture, racial and economic oppression, and mental health systems with too few resources and too narrow a mission will continue to undermine the emotional health and ties that bind humanity and which are foundations for collective action to pressing problems. So well-being centered policymaking needs to be a pillar of the future.
Nancy, you have about 3 minutes.
Perfect, thank you. So we need to address structural disadvantage which sustain collective trauma. Let's redefine mental health. Let's engage leadership from a vast array of stakeholders. Mental health and well-being should be participatory, coalition-driven, and hyper-local. So this means we need to see non-clinicians and non-specialists as experts in local needs and co-owners of healing practices. The concept of task sharing means looking at the adoption of skills and tools by non-specialists as people and peers to do much of the work of care, prevention, and promotion. And one of the principles of trauma-informed approaches is looking at how we can best mobilize peer mentors. Specialist clinicians can be capacity building partners and backup care providers. So this framework, rather than prevailing illness-driven specialist office-based models, should be the starting point for building systems and policy that finally acknowledge that most of the mental health and emotional suffering on the planet is driven by social conditions and choices that are under our control to change. So we need to challenge old habits, including over-medicalization, specialist and illness focus, hierarchical knowledge and practice, and little attention to social justice. We need to include an equity lens to all policy and research, invest in cultural change and leadership to drive these changes, and a shift in resources to communities that have historically been discriminated against and historically colonized. And the prize to do this is the well-being of all people. So in conclusion, COVID-19 pandemic shows the possibilities for people to come together in collective mobilization, mutual aid and solidarity, and the tangible linking together of mental health, illness, and suffering with the aims and paths of broader social progress and justice. There is much to build on. Let's start it. And I put in here the Nova Scotia Strong emblem because I've been thinking a lot about this also as a call to action. And you know, it really invites us to think about what it means when we say stronger together. So thank you very much.
Thank you very much. And thank you to all the speakers who have given us lots to think about. I'm wondering if there's anyone within the listening group who have any comments or questions that they would like to raise at this point. I'm a very retired, long-term retired person who worked in the mental health system. And peer support was something, I think through the rehab services in particular, that was being introduced, and there was training for peer supports. Is that still happening within the mental health system or not? Does anyone know?
There is peer support that still exists. I think it's at different levels. And there is training that is provided under the National Peer Support or like
Yes.
association or whatever. But I don't think, I think in pockets it's happening, but I don't think it's happening everywhere.
Right.
I think it's
And-
something that needs to continue to grow.
Right. And Celeste, I think, is saying that there is peer support in Nova Scotia. Celeste, did you want to comment?
Yeah, so I just wanted to share, previously I was part of a research project in Kentucky, and we looked at the utilization of peer support specialists as well as community health navigators as ways of both providing income and employment to a broader group of people, but also to provide extra support for individuals who are undergoing medical treatment. And we saw a profound rate of improvement in indicators and outcomes, as well as a significant decrease in cost. And so, for example, people who are in and out of the hospital 8 times in 1 year because of challenges managing their chronic health conditions. When provided with 6 weeks of follow-up care that included peer support specialists, they were not coming to the hospital emergency room even once over the course of that year, and they were able to be reconnected with the community and able to follow their regimen adhering behaviors as a result of the management of the chronic illness. So I would love to see more around the ways in which peer support can be utilized to address the profound challenges that the Nova Scotia health system has. And that's just one example amongst the many that we are looking at, as Nancy had mentioned, around how do we increase the understanding of what psychosocial determinants of health mean, and how do we ensure that they are integrated into healthcare, since our healthcare system is clearly cracking and in crisis.
Sandra, if I may make a comment, there is a movement I know in different places in Africa, and a friend of ours is doing the listening benches, where people just sit out, and it's known anybody can walk by and sit down and somebody will listen to them, and that is making a difference. So that's sort of happening. But what I find so interesting in my background in terms of working on the social determinants of health, I can go back to 1974 at the Alma-Ata gathering, the World Health Organization, that talked about primary care, primary health care. And it was from a community perspective, an empowerment perspective. And of course, the body is not divided up between your mental and your physical, your heart and your feet. It's all, you're all considered one. And that has been the Ottawa Charter for Health also talked about the determinants of health approach. This has been going on for years. And, you know, now we're talking about it specifically with mental health, but it's been an issue that it's been not taken up by governments because the research, it's known for years and years and years. That's, if you want to achieve well-being, you have to address the determinants of health. But it is a huge political issue because it's, if you really empower people at the community level, you're talking about shifting of power, and that's a very difficult thing to do. And I just want to leave with a quote that I've made before in some of these other presentations that I recalled from the Member of Parliament in Australia was, if we could see ourselves living in a society and not an economy, we'd be much better off. And all these decisions around healthcare and the medicalization, it's all about the economy. But if we look at society, every person in society is valuable to that society. And we're not going to stigmatize and judge people. We would accept them as being an important component of our society that contributes to everybody's well-being. Thank you.
Very, very well said, Colleen. Agreed. I was wondering, from the speaker's perspective, of course, we know that, you know, as Colleen says, this is an economic issue. And I think that was part of Nancy's presentation also, that it's really about what is the most, so the factory model, which I hadn't heard before, but it makes a lot of sense. What about sort of in a moving forward with a sort of new government? Do you see that there is a role for pressured advocacy for the mental health and having a different way and the inclusion of social determinants of health and not just the medical model to any and all of the speakers or any of the listeners?
Just for me, like, and I was around as you were, Sandra, when, and many others were probably around too, when they were doing the provincial strategic plan for mental health and addictions, which was a very collaborative effort because community was involved, as was the formal system. And I think we were making headway. I think we were really focusing on that person-centered approach to health and wellness, taking that holistic approach to meeting all the social determinants of health. Somewhere over the years, and we were breaking the silos down. And somewhere over the past few years, I feel like we've taken some steps backwards. And the silos are starting to rebuild. And we're taking a more fragmented view on health and wellness as opposed to that holistic person-centered view. So as all community agencies and so many others, we're continuously advocating to go back to what we had put so much time and energy in to developing in that strategic plan, and building upon that framework and foundation instead of, putting it on the shelf, tabling another strategic plan number 452, letting it build up dirt and dust, right? So I think that's the frustrating part. And we've been trying to advocate for 10% for years. And we're still advocating for that years later.
Great, thanks. Let's see, there's a number of comments in the chat. If any of those folks would like to speak them out loud, that would be great.
Hi, my name is Celeste. I'm coming to you from Antigonish. Hi, Nancy. It's really nice to see you, and Bev. I was involved with the project in Richmond County called Mind, Body, and Spirit, a collaborative approach to addressing seniors' mental health and social isolation in rural communities. And interesting enough, that took, we actually applied for the funding in 2016. The project lasted for 2 years, and it was really very much built on Nancy's idea about finding assets and strengths in the community, and multiple community partners were involved in providing services. So we were doing it in partnership with the formal system, but it was really tier 1, tier 2 type of response to addressing mental health outcomes, everything from connecting seniors through technology, to talking about issues of food insecurity, to working with seniors in nursing homes to capture their stories, intergenerational projects, to offering mental health first aid, to offering some of the CMHA programs like the Art of Recovery and the Art of Friendship. So this was very much community-based organizations offering this to seniors, because we said a long time ago, it's not one organization that's responsible for people's mental health, it's a community that's responsible for it. So I've developed a toolkit, which is going to be launched in the new year, and it's going to be available to community groups who want to learn more about the project.
Oh, great, good. Can you make sure that folks within the coalition have access to that? Maybe through Colleen or just through any of us?
Absolutely.
Great, great. Any other, so Sally, you had a comment, I see.
Yeah, hi, thanks, Sandra. Doing a great job here with the comments. I just wondered whether, given the importance of the social determinants of health and intersectionality that people have been talking about, and their contribution to mental health, perhaps there should be a focus not only on peer support, but also bringing various groups and social services together to talk about how we could, plan and think about cross-sector collaboration more. There is some of it taking place, but I just get the sense that, as Bev said, I think many of us are working, many service organizations are working in silos that with not much contact with others. Many years ago, up in Spryfield here, near where I live, there used to be something called the multi-service approach, and that lasted about 5 minutes, partly because of lack of funding, but I think it's a really good approach. I mean, there are things happening now at the community level here in Halifax where people share you know, as various organizations, I think funded through the United Way, where people share information about programs, but it's just sharing of information. It's not really coming together to say, let's do some advocacy, or let's plan together how we can share resources, or stuff like that. You know, it's just information, not really going forward to develop anything different. So I'm
Right,
just
because
throwing that
it
out
doesn't
there.
change, yeah, it doesn't change anything, but
Yeah.
yes, I understand, yes, yeah. Any other comments? I know that we're getting close to the end of time, and I'm sure that people have lots of busy days.
I had a comment, if I could.
Sure.
My name's Steph. I'm a PhD student at Dalhousie, secretary of the board at Be the Peace Institute. And so I also have lived experience of sexual violence and involvement with the criminal legal system. And so I'm not against advocating for cross-sector communication and advocacy. I think it needs to be done with a strong connection and rooting in the community. Otherwise, it just risks perpetuating things that we're already seeing. And so part of my role as a PhD student has been involved in a number of tables where cross-sector communication has been the goal, whether it's for the problem-solving courts on the steering committee. I've been involved in some of that work, and it's really great work, and people come together and they're really invested in making change. And I often think that, in a table of 20, 10, 30 experts, what's lacking is a strong community connection. Mm-hmm. First, a lot of the people around the table are usually in positions where the social determinants of health aren't something that's going to greatly impact their lives. And so the conditions that they're talking about and aiming to fix is coming from a lens where they may not have experience. So you don't really fully know what you're actually talking about, if you're going to be completely honest. Without judgment, it's just the way that it is. Number two, the solutions and things are coming with the tools that are at the table, which are often from colonial rule, from systems that are designed to oppress, that are functioning well when people are suffering. And so if we're continuously cross-sectoring, or what can the sector do, I think there's something missing. It's not fully there. And so I don't think cross-sectoral communication and tables should continue to happen if they're removed from the communities that they're intending to serve, because I think it's just going to keep falling short. And so I really think, in my comment before around peer support, great, there's training, but it's coming top down, right?
Yeah.
And the professionalization of peer support means that people are continuously going to be cherry picked and selected for specific roles, and you're going to be consumed into the system, much like restorative justice has been in criminal legal situations, right? Mm-hmm. So it's just a thought.
Yeah, very, very, very good comments, and I think it helps us all to realize that many of us do come here even today from positions that have never had any of these experiences. And so I think it's very important. And I think it's a really great way for us to probably end our session together, to say that indeed, we do not really know of what we speak if we haven't lived it, and missing that voice repeatedly does not always lead us in the direction that we need to go. So I thank you for expressing those thoughts. Very important. Unless there's any other last comments, again, in looking at the time, I think that I would end here. I think that there are many, many things that we have learned and that we'll take away. I know certainly for myself, I will. And we look forward to any comments that you have. And I think maybe Alex might send out an evaluation. I again want to thank everyone who did the presentations today. And I want to thank everybody who took the time to sign in and to listen, and also to make comments and suggestions of what might be next. So thank you all and have a great day.